Welcome to the Hormone Optimizing Warrior MD, the How MD podcast, your reliable and trusted source for information on hormone therapy for menopause and beyond, and on how to advance into the second half of your life with confidence and optimism, knowing your hormones are optimized in alignment and balance with everything else in your body. Whether it is hormone therapy, peptide therapy, laser therapy, or some other new technology applicable to maintaining our vitality, mental and physical strength, you will hear all about it in this podcast. And you will also hear how to implement the facts and information presented so that you can take action and optimize your hormones and optimize your body. Hello there. Today is Mother's Day, and I'm recording the episode that's launching the following Friday on May, I believe, 15. And in honor of all mothers, we want to keep our mothers alive as long as possible. Let's continue talking about heart health and what can we do to keep our moms healthy. In last week's episode, I started the conversation around the biological markers for cardiovascular health for menopause. I made the point that estrogen level and FSH levels are valuable indicators for a woman's cardiovascular health. This is not something you're going to hear from your cardiologist, your internist, your primary care doctor, and you're not going to hear it from your gynecologist unless your gynecologist is really elevated as far as heart education. But you should. This is a hot topic and it should be discussed. I talked about how important treating hot flashes is and how even though hot flashes are not considered dangerous, they're not life-threatening, right? We can live with hot flashes. They should be because they are dangerous and they can have serious consequences for a woman's, not just for her quality of life, but for a woman's cardiovascular status and cardiovascular health. So as promised in this episode, I want to focus on what to look for when your doctor is monitoring your cholesterol panel. Let's talk about cholesterol a little bit. And this could happen at menopause when you're not using any kind of hormone therapy, you're on no hormones, or it can happen during menopause, after menopause, as you're aging, while you are on hormone therapy. The cholesterol numbers matter. So how important is cholesterol in assessing your cardiovascular risk, the risk of a heart attack, the risk of a stroke? And then I'll also continue the conversation around how valuable medications are like statins or other cholesterol-lowering medication, especially for someone who is at risk. In the next week's episode, I'm going to bring the conversation around the idea of using a tool, risk analysis, which is available on the internet very easily, and is calculating the risk of a major cardiovascular event, and that's called the Framingham score. Now, starting this week's episode with the cholesterol profile, I want to start by stating the obvious. It would be real easy if we had a very simple blood marker to indicate heart disease risk. And we kind of do. For the sake of simplification, modern medicine is seriously focused on the lipid profile and the cholesterol level as being the main indicator or biological marker for heart disease. As soon as someone is thinking heart disease risk, they're immediately thinking, well, what's my cholesterol? We've been taught to believe that cholesterol and heart health are intimately connected together. And let me tell you why I believe everyone is so focused on cholesterol. Because it's something easy to understand. It's also something very easy for big pharma to focus on as a target of treatment. Therefore, every single doctor has been trained to believe that cholesterol is at the core of plaque formation and atherosclerosis. But guess what? Women's bodies are complicated. Looking at a woman's lipid profile, just that, and recommending a statin or another medication, and not taking into consideration all the other major issues that could exist specifically due to her menopause status, loss of estrogen, and the impact this creates in her body is very, very similar to treating a woman with horse blinders on. Now, First of all, let's talk about cholesterol numbers for a little bit. They have to be taken into context. And looking at cholesterol only will severely limit our ability to detect heart disease early. Now, it is very true that cholesterol levels, specifically the LDL and the HDL, the low density lipoprotein and the high density lipoprotein numbers, are valuable to understand cardiovascular health. But there are different types of lipoproteins carrying the cholesterol, which can be more harmful depending on their particle size. For example, smaller, dense LDL particles are much more harmful than the large LDL particles. Why? Because they fit through the gaps into the vessel wall created by the main reason for heart disease, the blood vessel wall damage. I'll get into that in a minute. Lipid particle size testing is much more important than the regular lipid panel that your doctor's been ordering. We need that to understand someone's real risk for cardiovascular events. Of course, we also want to look at the triglycerides. They are important. They're a separate risk factor for heart disease, and they're more linked to other health issues like obesity or insulin resistance. That's when your triglycerides go kind of on the high side. But let me come back to the lipoproteins I mentioned earlier. These lipoproteins are carrier proteins. Two of them are very important. ApoA is the primary component of HDL, our good cholesterol. This is an anti-inflammatory lipoprotein, and higher levels of this lipoprotein are generally associated with a very low risk of heart disease or a lower risk of heart disease. So we want high ApoA. ApoB is the primary component of LDL. That's the low density lipoprotein, and is the primary component of VLDL, the very low density lipoprotein. These make what we call the bad cholesterol. When your ApoB levels are high, it indicates a higher number of potentially plaque-promoting lipoprotein particles, which can unfortunately increase your risk of atherosclerosis and subsequently heart disease. The ratio between these two lipoprotein components is increasingly recognized as a very useful indicator for heart disease. A high ApoB-ApoA ratio is bad, whereas a high ApoA/ApoB ratio is good, suggesting a favorable profile. There is another marker for inflammation of the heart and the blood vessels, which is called Lp(PLA2). This is an enzyme produced by the inflammatory cells around the blood vessel and associated with the bad cholesterol particles. This enzyme will unfortunately hydrolyze the phospholipids in the vascular wall, causing the release of more pro-inflammatory mediators, initiating a cascade of inflammatory events and eventually leading to more and more plaque. Elevated levels of Lp(PLA2) means bad news for your cardiovascular risk because it's bad news for your cholesterol panel profile. The routine lipid profile is not going to include any of these markers I mentioned. Consider the fact that Quest has something called an advanced lipid particle size panel with inflammatory markers. This is going to give you all the numbers of all the markers I just mentioned. Not only will it measure the cholesterol numbers, but on top of that, it will measure the lipid particle size of all the lipoproteins. It will give you the ApoA and ApoB number, whether you have LDL pattern A or B, A for low risk, B for high risk. And it will tell you about the other inflammatory markers I mentioned, Lp(PLA2), high sensitive CRP, etc. So if you have a cholesterol problem, ask for an in-depth advanced lipid particle size with inflammation markers. Let's keep talking about cholesterol numbers. It's important, but they don't mean anything unless they're taken into context, because there are many women and men with very high cholesterol, like over 280, who will never have a heart attack and who live long lives, very long lives, into their 80s and 90s. And there are more women and men, unfortunately, with low cholesterol who will unfortunately go on to develop heart disease and possibly die of a heart attack or stroke because they have other more important risk factors than cholesterol. What would those risk factors be? Well, number one, and a little bit of the focus around what I'm talking about today, is inflammation. This is one of the most powerful risk factors, if not the most powerful risk factor for heart disease. This should be what anyone should look at when they're talking to you about your risk of heart disease or decreasing your risk for stroke or heart attack. There is a simple routine test that should be on everyone's annual menu of blood tests, and that is the high-sensitive CRP. This is a protein which increases in response to inflammation in the body. It is true. It is a very non-specific increase. So you have a bad tooth, it could go up. You have a severe joint inflammation, it's going to go up. You have digestive problems and gastroenteritis and autoimmune issues, it could go up. But if you don't have any of these things and you have elevated high-sensitive CRP, that's not good. It's very easy to measure. Quest, LabCorp, all major labs do it. Ask for it. Very easy to look at. It should be under 1. Anything over 1 signifies some form of inflammation. Low grade if it's 1 to 3, more significant at a higher number, over 3. High numbers, 5 to 10 and above, indicate moderate to severe inflammation. And regardless of what causes that inflammation, it will need to be addressed because inflammation is the trigger for plaque and heart disease. Now, guess what? I did mention earlier the lipid particle size panel with the inflammatory markers available through Quest. High-sensitive CRP is included in it. There are other inflammatory markers I'd like for you to know about. Interleukin-6 is a cytokinin. It plays a crucial role in inflammation, and it has been linked to high risk and actually worse outcomes, including coronary and peripheral artery disease, because this inflammatory marker acts as a central pro-inflammatory mediator of vascular damage. So high interleukin-6 is bad news for your heart. If the level is high, it's a good predictor for higher risk of heart attack, stroke, heart failure, and death. Do not forget, interleukin-6 is a major promoter of plaque buildup and inflamed plaque, which is the worst kind of plaque you can have. TNF, tumor necrosis alpha, also known as TNF-alpha, another cytokine involved in systemic inflammation, contributes to the development of plaque or heart disease in general, and we can check it. We can actually measure levels of TNF-alpha. And another valuable inflammation marker is the level of myeloperoxidase. This is an enzyme released by the white blood cells involved in the inflammatory process. The more white blood cells involved, the more plaque you have, the more of this enzyme will be released. There are a few of other markers which are not tested very frequently. I'm going to mention them here. It's useful for you to know. Fibrinogen is a clotting factor. And obviously, if the fibrinogen levels are increased, it's a sign of inflammation. And also, it's a sign of increased risk of cardiovascular disease because high fibrinogen promotes clotting. And we do not want to be in a high clotting state. A very important inflammation marker, it's also oxidized cholesterol, specifically oxidized LDL. It's a very important indicator and a useful marker to monitor. Again, this can be easily checked on a regular blood test with any major diagnostic lab like LabCorp or Quest. So I kept mentioning the word plaque quite often into this podcast episode. And you hear this word frequently when heart disease is being discussed because heart disease is the buildup of plaque in your heart arteries, leading to decreased blood flow and therefore less of oxygen to the tissues that are served by those arteries. And when the blockage is severe, ischemia happens, and when critical, then a heart attack happens. So it might be important for you to know some of the steps involved in the formation of plaque, so you can understand why these markers I just talked about might actually be important and how measuring them would give you a much adequate picture than, let's just look at cholesterol. How about we look at cholesterol with lipid particle size and all these inflammatory markers I mentioned? So allow me to take you through some of the steps of how plaque is formed in our bodies. The process of plaque formation always begins with some sort of damage to the endothelial cells. These are the cells that are lining the interior of the blood vessel. Environmental toxins, stress, high blood pressure, smoking, diabetes, inflammation, and more are some of the factors involved in the initial damage of the blood vessel wall. And whatever the factor is that causes the damage, it will compromise the integrity of the endothelial barrier, making it permeable. Remember, this is always the first step. Damage of the blood vessel inner lining, the endothelium. Once the blood vessel wall becomes more permeable, which in layman terms means leaky, to create a better visual for you, there are some tight junctions between the cells, and these junctions are damaged. Now, the LDL particles, the cholesterol particles, the bad LDL, the bad cholesterol, will infiltrate the arterial wall because these junctions are now loose. And the step 2 is lipid accumulation. At the same time, there is an inflammatory reaction already present in the wall. Remember, the wall is being damaged by something, right? This inflammatory process happening in the blood vessel wall will cause the oxidation of LDL. This is a process catalyzed by free radicals, reactive oxygen species called ROS, and other factors. So now the regular LDL has become oxidized into oxidized LDL. This is a promoter of inflammation and will continue to accelerate this cascade and will trigger step 3 of plaque formation, which is an activation of the immune response. What this means is that now the immune system cells called monocytes, this is a type of white blood cell, will move from the circulating blood into the arterial wall, transforming into a different type of cell called a macrophage. In step 4, these macrophages will consume the oxidized LDL. When they consume large amounts of this oxidized LDL, which is the inflamed bad cholesterol, they transform now, the macrophages transform into what is known as foam cells. And these foam cells begin to aggregate and cause fatty streaks within the blood vessel wall. This is the early stage of real plaque formation. So it begins with the damage to the blood vessel wall, the immune system activation, and the lipid accumulation, which are setting the stage for now in earnest plaque formation, which is really accomplished when the foam cells start forming. Now, do not forget the foam cells are macrophages eating the oxidized LDL. Without these macrophages eating up the cholesterol, we wouldn't have foam cells. Without inflammation, we wouldn't have the macrophages being deployed. And without blood vessel wall damage, we really wouldn't have any inflammation. You know, I hope, that inflammation is the body's natural localized immune response to either an injury, an infection, or any kind of irritation that's designed to protect the tissue, in our case, the blood vessel wall, and attempt to heal the damage. Inflammation is a natural response essential for our survival. We are equipped with everything we need to heal. And acute inflammation is great. But chronic inflammation from persistent damage to the endothelial lining will cause serious damage and disease if it becomes chronic. So coming back to plaque formation, we had the blood vessel wall damage, then inflammation as a response to that, then immune response activation, then foam cell formation when the oxidized LDL is consumed by the macrophages. What follows in the next step, which is step 5 now, is a smooth muscle cell migration and proliferation from the medial layer inwards towards the intima layer. So the muscle cells are migrating from the outside towards the inside, towards the innermost layer of the blood vessel wall, in response to all the growth factors released by the immune system cells, which have migrated and aggregated in the area where the plaque started. Over time, the combination of the foam cells, the smooth muscle cells, and all the proteins coexistent in the extracellular matrix, they all accumulate to form a fibrous cap over the fatty plaque. This is then the bulk of the plaque formation. This is the development of the plaque. Let's call this step 6. The plaque will continue to grow as more oxidized LDL particles and more cells are coming in, creating a very complex structure that's now narrowing the blood vessel wall, and constricting the blood flow downstream. A few words about the calcification of the plaque. This is a separate process. It happens in some cases, and it's due to a process of mineralization where the calcium salts will deposit in the plaque. Luckily for us, this makes the plaque more stable, but will unfortunately contribute to the stiffening of the blood vessels, which will also increase the risk of high blood pressure. A few words about the plaque rupture and the final clinical event, heart attack, stroke. When the plaque has grown too large or is experiencing significant inflammation, the fibrous cap, that is the final layer that's covering the plaque, will rupture, exposing the underlying lipid core to the bloodstream, which will now trigger the formation of a blood clot, also called thrombus, because the platelets in the circulating blood will aggregate at the rupture site to try and repair the damage, and they will form a clot. If this thrombus/clot is large enough, it will occlude either partially or completely the artery involved, leading to a reduction in the blood flow that needs to go and irrigate the tissue dependent on that specific artery, therefore compromising it. This is what causes the heart attack if the tissue involved is the heart muscle. And this is what causes the stroke if the tissue involved is the brain. Now, keep in mind I went through this, let's call it the didactic and detailed educational presentation to explain how the plaque forms. And I'm sorry if I became too esoteric about it, because I want you to get the truth. The cholesterol is literally an innocent bystander caught up in a storm of inflammation and damage, which once activated, obviously cholesterol is part of it, whether we like it or not. And that's what we need to focus on, not the cholesterol. In the upcoming episodes, I will continue the discussion on cholesterol numbers and how they're influenced by estrogen and some of the other hormones. And in next week's episode, I will definitely want to discuss the cholesterol lowering drugs and what's their value in prevention as well as treatment of high cholesterol. Now, I know the conversation around all the steps of the plaque was pretty long, but please listen to all the steps again. And once you have them clear in your mind, ask yourself, which one of these steps could the big pharma companies and the conventional 10-minute office visit approach to everything target? Not the damage to the blood vessel wall that is due to way too many factors. It will take serious detective work, as well as serious testing and detailed history taking of the patient, which will require time we never have, but that would be addressing the root cause. So instead of addressing the root cause, doctors, what are they doing? They're lowering the available cholesterol, which can circulate to deposit in the plaque, attempting to stem the tide of damage and inflammation by starving it of the circulating lipids. That is not quite how the body works. Unfortunately, we will have to lower cholesterol to dangerous levels for the rest of the body in order for this theory to work on everyone and be used with the successful outcome of preventing a heart attack and the stroke the doctors and patients are hoping for. In next week's episode, I will focus on cholesterol and a risk assessment tool that I believe you should be aware of. And I'll give you some information on how to play with that tool to assess your risk factor. And you can do that online, and I'll provide the links in the show notes. That should be fun. And the week following, I want to discuss a valuable available tool that will allow doctors to detect plaque. That's unfortunately rarely used or recommended, but I believe should be standard of care for all women, especially once they have reached 2 to 3 years into menopause. Now, for all these and more, stay tuned. Remember, I am now the How MD, the hormone optimizing warrior, in full force, fighting for you to know the truth and understand what could be the best route, the best treatment when confronted with the dilemma of choosing between all available options or different alternatives. I'll be in your ear next week. Thank you for the time and energy you spent listening to my podcast. If this episode or another have caught your attention and delivered valuable information you have not heard anywhere else, and if you feel I have succeeded in my mission to provide the how to stay healthy and age beautifully, please leave me a review. Your opinion matters to me, and any suggestion to improve the podcast will help make it better for you and for others. You can send my staff a message directly by sending an email to receptionist@herahealthcare.info. I look forward to recording my next episode and being in your ear again.